I'm going to discuss today imaging in early, and I mean early, initial onset acute uveitis associated with Vogt Koyanagi Harada disease. The reason that I selected this topic and this lecture, because I'm going to show you data now that patients with VKH disease, with the early presentation cases, if you treat them early and aggressively with immunosuppressive therapy, you change their life. And you can cure their disease. You can induce long-term remission. And the patients, they don't need to receive repeated courses of immunosuppressive therapy. Therefore, I'm going to focus on imaging in this particular phase. Why? Because many of these patients, at early presentations, they are misdiagnosed and not diagnosed by ophthalmologists. Ophthalmologists, so far, they found a lot of difficulty in diagnosing these cases. And most likely, these cases are misdiagnosed as central cells choroidopathy or pseudotumor cerebri, and with unnecessary referrals. And this, of course, this will result in delaying treatment. So imaging also, so allow us to help us, or to help in experiencing ophthalmologists to make early diagnosis, and also allow us to better understand the pathophysiology of the disease and how to avoid complications. So uveitis associated with Vogt Koyanagi Harada disease is characterized by, it is a bilateral, there is no unilateral VKH, it's bilateral. It's granulomatous choroiditis, and the exudative retinal detachment is a secondary phenomenon. So the exudative retinal detachment is secondary to granulomatous choroiditis, that, and I'm going to explain later. We have to know that this is the most important staging of the disease. So the clinical manifestations at presentation depends on the duration of the disease before presentation. Those patients who present very early, we call them in the phase preceding anterior segment inflammation, because the early VKH, the early uveitis in VKH, is confined to the posterior retina. It's granulomatous choroiditis, exudative retinal detachment, and inflamed optic nerve head. So there is optic nerve head inflammation with or without swelling. So this is the early presentation. Quiet anterior segment, clear vitreous, inflammation is localized on the posterior segment. And this is the phase where most of the wrong diagnosis is made. Because the ophthalmologist puts the patient lamp, anterior segment is quiet, vitreous is clear, localized exudative detachment in the posterior retina. Oh, this is central cells choroidopathy. Or patient presenting with headache, optic nerve head swelling, or pseudotumor cerebri, refer to neurology. And the patient seen by neurology, he doesn't know ophthalmology, he will order MRI, he will do lumbar puncture. We have so many patients like this. So the early phases, the phase preceding anterior segment inflammation is very critical phase. Then if the patient is not receiving adequate treatment, then the anterior segment will be inflamed with multiple fat capillaries with cells in the anterior chamber. This is still initial onset acute disease, but the early presentation phase is the phase preceding anterior segment inflammation. The late presentation phase is the phase with anterior segment inflammation. Now the patient, it happens around us, although the disease is the most common cause of autoimmune eye inflammation in the kingdom. But so far, the disease is not diagnosed properly, is not diagnosed, as not treated properly. So if the disease is not well controlled, and the patient not adequately treated, the disease will progress into chronic recurrent phase. And this is the worst situation that can happen in a patient. You know, what does it mean, chronic recurrent phase? The disease is resistant to treatment. The patient needs repeated courses of immunosuppressive treatment. All the complications can happen during this phase. Complications of glaucoma, of cataract, sunseed-glofundus, chorioretinal atrophy, choroidal vascular membranes, subretinal fibrosis, which can be pigmented. We know that sunseed-glofundus is the result of progressive subclinical inflammation at the level of the choroid. In the past, we were told that sun-singular fundus is a part of the natural history of the disease. This is not correct anymore. Sun-singular fundus is the result of inadequate control of inflammation at the level of the choroid. And we have to avoid sun-singular fundus. So in our efforts to understand if there is a window of opportunity in the management of VKH disease, we conducted this study that I'm going to as an introduction to my presentation. So we defined the therapeutic window of opportunity. So what do we mean by therapeutic window of opportunity? Therapeutic window of opportunity is a concept which is best studied and evidenced in rheumatoid arthritis patient, another autoimmune disease. It is demonstrated that this is a time interval in the initiation phase of autoimmune disease. This is the first early phases of the initiation of the autoimmune disease, and the critical period during which early effective suppression of inflammation may alter the disease course by preventing chronicity of the inflammatory process, thus reducing the rate of long-term structural damage and inducing permanent remission. You can induce permanent remission if you treat autoimmune disease very early in the course of the disease. This window represents a very early phase in which early effective treatment might allow modulation of biologic processes while they are in the immature phase of the disease, in the very early phase of the disease. Defining proofs of this concept and understanding whether there is a time-limited window of opportunity in the acute uveitic phase of VKH disease is of critical importance. If such a phase is present in the initial phases of VKH disease, then all our efforts should be done to diagnose the disease early and treat it early. So we conducted this study. It was a retrospective study. We had the help of Dr. Muhannad, Dr. Faisal al-Rashid, who did a lot of work to collect the data and also from the side of our statistician. So in this study, we determined in a large cohort of patients the relationship between timing of treatment, initiation, and the disease outcomes. Of course, we didn't rely on the history given by the patient, on duration of the disease. We relied only on our slit lamp examination. So those patients who have anterior segment inflammation, this is delayed presentation, and those patients who presented early, they have a quiet anterior chamber. So with our examination at presentation, 46 patients, they presented in the phase preceding anterior segment inflammation. So this is early presentation. And 66 patients presented late in the phase with anterior segment inflammation. Among these patients, most of them, they had bullous exudative detachment spreading to the periphery. Typically, in the early phases or the early phase of the disease, the exudative detachment is confined to the macula. If the patient comes late, then the detachment becomes bullous and extends to the periphery. And this is the manuscript that was published recently this year. And we published before, and I discussed this before, that our ideal treatment for this patient is to start this patient on the combination of systemic corticosteroids and immunomodulatory agents such as mycophenolate mofetil, because we know that this combination of treatment as first-line treatment will prevent progression into chronic recurrent evolution and prevent some singular fundus and other complications. So by looking at the result, So this is the table that shows the difference between early presentation and late presentation. If you look here, you can see that sunset fundus developed in about 60% of late presentation and in none of the eyes with early presentation. Chronic recurrent evolution in none of the eyes with early presentation and in about 30% of delayed presentation. So the difference was very striking, that patients with early presentation, they had no complications, they had no chronic recurrent evolution, they had no sunsingular fundus. And most of them, they ended with 20/20 vision. So this data allowed us to tell that the window of opportunity is here, in the early presentation group. It's a very challenging finding, meaning that we have to do all our efforts as ophthalmologists to diagnose the patients early and treat them early and effectively. This is an example. So, as I said, early presentation group, the oxidative detachment is confined to the central retina. And then you can see the patient ended with no sunsingular fundus. And the late presentation group, look here, what do you see here? Huh? Bullous oxidative spreading to the periphery. It's a sign of delayed presentation. And this patient with delayed presentation, he ended with sunsingular fundus. And this is another example of a patient. Another example of a patient with early presentation. The oxidative detachment is confined to the central retina, and the patient ended with sunsingular fundus, and we were able in this patient to stop the treatment and to follow up these patients for a long period without any flare-up. So patients with early presentation, you can, after completing the course of systemic corticosteroid plus mycophenolate methylphenidate, which is about 16 months, you can stop the treatment and the eye remain quiet. So this Kaplan-Meier survival curve told us that patients with the early presentation group were able to discontinue the treatment at significantly shorter duration compared to patients in the delayed presentation group. And they remained quiet. There is increased chance for earlier drug-free sustained remission when patients were treated in the phase preceding anterior segment inflammation. So in the phase, if we catch the patient in the phase preceding anterior segment inflammation and treat aggressively, we cure the disease. So the conclusions of this study is that our results support the notion of the presence of a window of therapeutic opportunity in initial onset acute VKH disease in the phase preceding anterior segment inflammation. The time when the patient presents with anterior segment inflammation is already late, during which uveitis is more susceptible to treatment. Early diagnosis of initial onset acute uveitis treated with VKH disease and the prompt institution of effective treatment combining systemic corticosteroids, as we discussed many times before. Systemic corticosteroids are not enough to control the disease, and immunomodulatory drugs as first-line therapy is going to have increasing importance in clinical practice. Therapeutic approaches should be modified according to whether treatment is started in the early phase or late phases. So our findings also indicate that similar to rheumatoid arthritis, catching the therapeutic window of opportunity in the very early phases of initial onset acute uveitis associated with VKH disease prevents progression to chronic recurrent evolution and development of complication. That's why, with the help of an international group of colleagues, but this is before we published this paper, we published a review article hypothesized the importance of therapeutic window of opportunity, and the title is Catching Therapeutic Window of Opportunity in Early Initial Onset Vogt Koyanagi Harada Disease Can Cure the Disease. So, unfortunately, among these 112 patients that were included in this study, about 60% had anterior segment of inflammation presentation because they are coming late. Unfortunately, the reason for that is that many ophthalmologists are not aware of the clinical signs of early onset acute uveitis, and they frequently misdiagnosed as central cirrus choroidopathy. So the major challenge here is to educate ophthalmologists how to diagnose this disease early. In two papers, there are two papers that looked at this issue. In the first paper, 22% of patients with VKH disease were initially misdiagnosed as central cirrus choroidopathy. In another study, 14% of the patients with VKH disease were misdiagnosed as central cirrus choroidopathy. So how can we prevent this? How can we make the early diagnosis and proper diagnosis? If you look at, there are several papers in the literature that look at this issue, how OCT can help us to differentiate between early VKH disease versus central cirrus choroidopathy. So the OCT findings that are in favor of VKH disease are, number one, retinal pigment epithelium undulation. I'm going to show you examples of folds. Number two, subretinal septa or membranes. It is thought that, I don't agree fully percent with this, it is thought that this subretinal septa might represent part of the outer photoreceptor segment layer that is separated from the inner segment layer by cystoid spaces. Subretinal hyperreflective dots, which represent clumps of inflammatory debris or macrophages engulfing shed outer segments. Intraretinal edema in the outer retinal layers, fluctuation of the internal limiting membrane, and thickened choroid. The features that are in favor of central cirrus choroidopathy are the presence of retinal pigment epithelial detachments, or RPE bulges. These are more common in central cirrus choroidopathy. Another important feature here is that the presence of optic nerve head inflammation is a feature of VKH disease. I always tell this. There is no VKH without optic nerve head inflammation. So these are the examples, like the folds or undulations of the retinal pigment epithelium, like in this patient with shallow fluid, and subretinal septa, another patient with subretinal septa. The next imaging modality that will help us also to confirm the diagnosis of acute VKH is endocyanin green angiography. In a study that we published some years ago, we looked at endocyanin green angiographic features in patients. We had perhaps the largest number of patients ever studied with ICG to report the ICG findings. And the most common, we had 36 patients, 72 eyes at that time. So hypofluorescent dark dots representing granuloma was present in 100% of the cases. For us, is an important sign and the easiest sign to detect to confirm the diagnosis of VKH disease. Fuzzy or lost pattern of large stromal visits 100%, early hyperfluorescent stromal visits 83%, hypofluorescent patches corresponding to areas of detachment in about 83%, and so on. I'm going to show you an example. So this is a case of early initial onset VKH. Even clinically, you can see the granulomas, the yellowish granulomas under the retinal pigment epithelium, as you can see here. And here you can see more exudative retinal detachment. Fluorescein angiography is very typical. In the very early phases, we always see hypofluorescent spots corresponding to the granulomas. In fact, the granulomas can be seen in the early phases of fluorescein angiography. And then optic nerve head inflammation and extensive leakage and pooling of dye. This is the other eye. You can see the hypofluorescent spots, and then you can see the pooling of dye. So with this fluorescein angiography, you cannot miss this case for central cirrus choroidopathy. Looking at the ICG, you will not have this in central cirrus choroidopathy. The ICG, as you can see here, is full of granulomas. Each of these hypofluorescent spots are representing granuloma, and thanks to my colleague and friend, Professor Carl Herbert, he is the one who really started the ICG imaging to diagnose choroidal involvement in uveitis. And this is a patient after treated effectively with immunosuppressive steroids and mycophenolate mofetil without sunstick-glofundus. So this is another patient. You see, this is very shallow oxidative replantation. Can be easily misdiagnosed as cystic rhodopathy, but look at the amount of granulomas. Another patient, these are all early cases, and the ICG will show you the granulomas. So if you are in doubt, insulin grain angiography is very useful. We recently published a short paper. As I said, there is nothing called unilateral VKH. But sometimes we see patients coming to the emergency room with unilateral exudative retinal detachment. This does not mean that the patient has unilateral VKH, because you have to look at the choroid. If you look at the choroid, then with ICG, then you will see the granulomas. And that's what we did in this 10 patients. This is one of the patients. He had the exudative detachment was only in one eye, but when you do ICG, granulomas are present in both eyes. Then we used also imaging to understand the prognosis of the disease and the impact of sunstick-glofundus on the outcome. And this resulted in a paper where we studied macular sensitivity and macular function using macroperimetry. As you know, Snellen visual acuity is used extensively, and the Snellen visual acuity is not the best way to assess macular function. It's a very good way to assess macular function. So we wanted here to see what is the effect of sunstick-glofundus on macroperimetry, on macular function. This is an example of a patient that presented early in the initial phase of the disease and treated without sunstick-glofundus, and here macroperimetry. This color code will tell you that red is 0 decibel, the best sensitivity is green. So this patient ended with about 12 decibel in the right eye and about 12 in both eyes. Patient improved. But this is still not optimal result, because in this age group, the normal macroperimetry sensitivity is 19.6 decibel. So although the patient achieved the 20/20 vision, but still the sensitivity is less than normal. Another patient ended without sunstick-glofundus and 10 decibel in each eye. Look at sunstick-glofundus. Sunstick-glofundus, chronic recurrent disease. Although the vision 20/30, but look at the decibel, 5.3, 1.9. So the macular sensitivity is severely reduced.
Do they complain?
And they don't complain. It is severely reduced. مش واخد بالك انك قاعدين It's severely reduced. Another patient, 20/30, 20/20, and the decibel White, John. I think I'm going to Thank you. So here's the sensitivity in the right eye, 5.3, 1.9 in the other eye. Although the vision was excellent. So it means that patient with sensitive fundus, they have good vision according to Snellen visual acuity, but the sensitivity is severely reduced. And that's why the studies in VKH that looked at main outcome, only vision, were not correct. This is another case with sensitive fundus ended with here 1 decibel. And look here, everything is red. So the conclusion here is that patients who end with sensitive fundus, even if the vision is good, still visual acuity is good, but the macular sensitivity is severely affected. In another study using also macroperimetry, we wanted to investigate the effect of immunosuppressive therapy on the macular sensitivity in a group of patients with initial onset acute VKH disease. So we wanted to look at the correlation between best corrected visual acuity, macular sensitivity, because the macroperimetry allow us to study fixation stability. And it gave us a numerical value for the fixation stability. So we looked at best corrected visual acuity and macroperimetry to quantify the long-term macular function changes in patients with VKH disease in the acute uveitic phase treated with immunosuppressive treatment. Of course, we analyzed the data. We converted the Snellen visual acuity into logMAR visual acuity. So what were the results? If you look at the logMAR visual acuity started to improve and became maximum at 3 months and remained the same. So the vision improved very quickly, and at 3 months was maximum and then remained the same. And this table will show you this. The best corrected visual acuity became maximum at 3 months and then remains the same up to 1 year. But looking at mean retinal sensitivity, of course, increased up to 3 months, but still continued to increase up to the last follow-up. So it improves more slowly. Fixation stability, the same like vision. At 3 months became maximum and then remained stable. So the macroperimetry mean retinal sensitivity at baseline was severely impaired and ranged from 0 decibel to 14.7 decibel, and the mean was about 3 decibels. Mean retinal sensitivity continued to improve up to the final follow-up. However, and this is very disturbing, however, at 12 months, the macular sensitivity was still not optimal. So it reached at 12 months 12 decibels. I told you in the normal population of the same age, the normal is 19.6 decibel, meaning that in patients with VKH, at least up to 1 month, there is a status of photoreceptor damage. It can be permanent damage of the photoreceptors. Even the eyes had best corrected visual acuity of 20/20, suggesting prolonged photoreceptor dysfunction. This can be due to the exudative detachment, can be due to pathology at the level of the choroid and retinal pigment epithelium. And then by looking at sensitivity, you can see it continued to increase up to the 12 months. Fixation stability, as I said, continued to improve up to 3 months and then remained the same. And then here we compared between the improvement in visual acuity, logMAR visual acuity, and sensitivity. And you can see that the visual acuity tends to improve faster, but the sensitivity slower. These are examples for patients with delayed presentation because of exudative retinal detachment. And at presentation, the sensitivity, 0 decibel. They lose macular function because of the disease. And after treatment, it improved, but not to normal, because we still see a lot of red areas, which means 0 decibel. Another patient at presentation, and then sensitivity continued to improve. So the conclusions that we can make from this study, that patients displayed markedly decreased corrected visual acuity, fixation stability, and mean retinal sensitivity at baseline, reflecting severely impaired macular function. Best corrected visual acuity and fixation stability and domain sensitivity significantly increased from baseline after treatment. The beneficial effect was obtained as early as 1 month after treatment. Best corrected visual acuity and fixation stability recovered earlier, faster, and better than mean retinal sensitivity. At the final follow-up, mean retinal sensitivity was still significantly reduced even in eyes with full recovery of best corrected visual acuity. So what does this mean? It means that the use of microperimetry, MAP1 microperimetry produced by NIDIC, enable us to evaluate accurately the retinal sensitivity of eyes with acute uveitis associated with VKH disease after immunosuppressive therapy. Our data reveals that distant Snellen, best corrected visual acuity, alone significantly underestimates the impairment of photoreceptors and that subclinical macular dysfunction is a permanent damage in VKH disease. Then, to continue our efforts to image VKH disease, to image the eyes of patients with uveitis due to VKH disease in order to understand the pathophysiology of the damage. We studied also ocular blood flow in these patients. We are lucky to have in our department a machine called laser speculophy that allows us to quantitate blood flow both in the choroid and on the optic nerve. So why it is important to understand blood flow in patients with VKH disease, especially choroidal circulation. As you know, choroidal circulation represents the major supply of oxygen and the nutrients to the choroid and the retinal photoreceptors. So the photoreceptors are dependent on the choroidal circulation, and any impairment in the choroidal circulation will affect the function of photoreceptors. Why the choroidal circulation will be affected in active VKH disease? If you look at histopathology, as I did many years ago when I looked at sympathetic ophthalmia, you will find that the choroid in these patients, in the acute phase of the disease, is very sickened. Why sickened? Because of edema and because of severe granulomatous inflammation. And the edema and the granulomatous inflammation will compress the vessels and will cause what's called inflammation-impaired choroidal circulation. Therefore, significant decrease in choroidal blood flow might occur due to compression of the vessels by edema and granulomatous inflammation. Therefore, knowledge on choroidal blood flow in patients with initial onset VKH disease is important to understand choroidal pathological changes, pathogenesis of complications such as sunsequential fundus and chororetinal atrophy if the inflammation is not controlled. We use the laser speculophy. It's very easy to be used. Our technicians are trained to use it. In fact, our technician Abdullah used to tell me, Prof, this patient had VKH because I could see the choroidal circulation is severely impaired. He knew by experience that I'm going to show you. So the laser speculophy uses the laser speckle phenomena to detect the speckle contrast pattern produced by the interference of illuminating laser light that is scattered by the movements of erythrocytes. So it depends on detecting the movement of erythrocytes in the blood vessels. The changes in the contrast pattern enables the device to calculate the relative value of blood flow velocity in the vessels in the optic nerve, choroid, and retina. We know that outside the optic nerve, about 90% of the hemodynamic speckle pattern originates from the choroid. The laser speckle photography measurement parameter is called mean polar rate, which serves as a quantitative index of blood flow velocity. So in this study, these are the type of patients, this initial onset acute VKH disease. And here, this is one patient. To evaluate the optic nerve head, we position a circle the same size as the optic nerve on the optic nerve. So the blood flow in this area is representing blood flow in the large retinal vessels. And then the same size circles is positioned at the temporal edge of the optic nerve here to quantitate the blood flow in the choroid. So this is called rubber band 1, rubber band 2. So we have two readings that originate from the machine, one from the optic nerve representing the large vessels, one from here representing the choroidal vessel. So this is a patient at presentation. Then we have a color scale. Blue means very low velocity, and red, high velocity. Now, you can see this is an example of a patient. This is before treatment, and this is after treatment. So what kind of a change happened after treatment? Huh?
Green.
The color changed. It became green. And then the machine will give you a print about not only the blood flow velocity in MPR, but also about waveform parameters that I'm going to discuss now. So if you look here at the MPR, which is indicative of velocity, at baseline it was only 6. It continued to increase up to 11. So the M.Abu, which is representing the blood flow velocity of the choroid, continued to increase up to 12 weeks. We did the study up to 12 weeks. Now, looking at this are what we call it waveform parameters, because the waveform is synchronized with the heartbeat. So this is something called BOS, or blowout score. Blowout score was low at presentation and continued to increase. Resistivity index was high and continued to decrease. Both blowout score and resistivity index represents resistance to blood flow. Then you can see that the resistance to blood flow is decreasing with time. So we have increasing choroidal blood flow, and we have velocity of choroidal blood flow, and we have similarly in the optic nerve. The optic nerve can give you 3 readings. In the vessel area, so this reading will come from the large vessels, and then the tissue area. It gives you blood flow in the small blood vessels of the optic nerve, and then overall. Then you can see that in the 3 layers we have progressive increase, the same also. And we attributed that the decrease in the blood flow in the optic nerve is due to swelling of the optic nerve at the time of presentation. Exactly, this has been shown, but using other modalities in patients with papilledema. The blood flow will decrease in the optic nerve. So we showed here that immunosuppressive therapy is very useful to improve choroidal blood flow and even hemodynamics of the choroidal blood flow. So why this is important? Because as I said, the photoreceptors depend on, for their oxygen supply nutrients, on the choroid. So we need to improve the choroidal blood flow as soon as possible to improve nutrition to the photoreceptors. So this is the main conclusion here, is that early and adequate immunosuppressive therapy is needed to preserve the function of photoreceptors by improving the blood flow. Then, we recently completed a study we submitted recently to the literature, we did not hear yet from the journal, in which we wanted, as I said, one of the main mistakes done in the practice is to misdiagnose early VKH cases as central serous choroidopathy. So we wanted to know, to study the blood flow and hemodynamics in these 2 conditions, early VKH disease versus central serous choroidopathy. Is there a difference in choroidal blood flow between the 2 conditions? So we know that acute central serous choroidopathy and Vogt Koyanagi Harada disease in the acute uveitic phase are characterized by serous retinal detachment caused by dysfunction of the choroid. Both these conditions, they have dysfunction of the choroid. Central serous choroidopathy and VKH. And both this condition, they have neurosensor retinal separation. So the aim of this study was to compare blood flow velocity and pulse waveform parameters in the choroid between these two diseases. So the difference was very impressive. This is choroidal blood flow. We had age and sex matched control people, number 30 eyes. Central cells choroidopsy, we studied 27 eyes, and VKH, we had 50 eyes. So now if you look here, you see this is the normal 8.3 choroidal MBPR. Central cells choroidopsy is significantly more, 10.6, and in VKH, significantly less. So the choroidal blood flow in central cells choroidopathy is significantly more than the control. In VKH is significantly more less than the control. And with pairwise comparisons, this is the difference between control and center. With pairwise comparisons,
you're going forward.
Is it forward? With pairwise comparison, you can see that there is significant difference. The p-value between control and central serous choroidopathy is significant, meaning that central serous choroidopathy patients, they have significantly higher blood flow velocity compared to control. Control and VKH, meaning that patients with VKH, they have significantly less blood flow velocity compared to controls. And of course, between central serous choroidopathy and VKH, the difference is significant. So this is an example of a case. This is VKH, the acute uveitic phase, OCT, fluorescein angiography, ICG, and look at the color, blue. So very low blood flow velocity in this patient. Now, central serous choroidopathy, clinical finding, OCT, fluorescein, and then look at the color. Big difference. So our findings confirm different pathophysiology of these two diseases. Assessment of choroidal blood flow velocity and hemodynamics with laser spectrophotometry provides useful information to differentiate acute central serous choroidopathy and initial onset acute VKH disease. Compression of the vessels by edema and granulous inflammation interfere with choroidal blood flow velocity and induces choroidal circulation impairment in patients with VKH disease. Our laser spectrophotometry findings suggest that increased choroidal blood flow velocity and the choroidal hyperperfusion are involved in the pathogenesis of acute central serous choroidopathy. Big difference between the two conditions. So that means that perhaps in departments that have laser spectrophotometry machine, it can be useful to confirm the diagnosis of central serous choroidopathy versus acute VKH disease. Related to imaging, looking for biomarkers of inflammation is also imaging, because biomarkers of inflammation will help us to find new targets for treatment. And through the years, we were looking at different biomarkers, comparing between VKH, Behçet, HLB27, sarcoidosis, and others. And we came with very simple conclusion that cytokines, chemokines that chemoattract and activate neutrophils and lymphocytes, T helper 1 lymphocytes, are more prominent in Behçet disease and HLB27. And cytokines and chemokines that act predominantly on B cells, B lymphocytes, are acting predominantly in patients with VKH disease. So we demonstrated in 2 independent studies using 2 groups of samples and 2 kits, multiplex kits, that the level of the B-cell chemoattractant, CXCL13, in the aqueous humor samples from patients with uveitis treated with Vickers disease largely exceeded Behçet disease and HLB27. In these studies, the concentration of CXCL13 in the aqueous humor samples were quantified in 2 sets of aqueous humor samples with the use of 2 multiplex assays. CXCL13 is a chemokine that belongs to a group of CXC chemokines, and it acts through one receptor, CXCR5, expressed on B lymphocytes. And it is a potent B-cell chemoattractant and activating factor. So this, as I said, this done in 2 independent studies. That was the first study. The cytokine interleukin-6 and chemokine CCL20 and CXL3 are novel biomarkers for specific endogenous uveitic entities. In the same journal, differential CXC and CXC3C chemokine expression profiles in the aqueous humor of patients with specific endogenous entities. There was like about 3 years between the 2 studies. But we have the consistent finding that CXCL13 is a biomarker for Vickers disease. What does this mean then? It means that compared to other uveitic entities, B lymphocytes are the ones that are involved in the autoimmune, in this autoimmune disease. I discussed this last week to the residents that B cells are currently well known to be very important in the pathology of autoimmune diseases, such as multiple sclerosis, such as rheumatoid arthritis, and systemic lupus erythematosus. It is not, these diseases were known for years to be mediated by T cells, but now B cells are very important in the pathogenesis of autoimmune diseases. What does this mean? It means that B cell depleting therapy with drugs like rituximab, which is anti-CD20, will be effective in this particular disease. And I gave a very interesting example. Patient who was admitted with neurology, they saw that this patient had MS, multiple sclerosis. As you know, in patients with multiple sclerosis, you cannot give anti-alpha agents because it causes demyelination. So the patient was treated with rituximab, which is known to be effective for multiple sclerosis. But despite rituximab, the patient became worse, and he came to our hospital. I discussed the case with Dr. Ahmed Belushi. And when I looked at the eye, this is typical for Behçet disease. This cannot be multiple sclerosis, inflammation of the eye. We communicated with them. So despite the fact that she had rituximab, she didn't respond, became worse. But when we started infliximab, she immediately improved. This example will tell you that when you select the biologics to treat autoimmune inflammation of the eye, you have to select the biologic based on good understanding of the pathogenesis and the immune response of this particular case. So this is a graph from one of the study. We looked at what's called lymphoid chemokine. CXCL12, no difference between the 4 diseases, but CXCL13 was significantly highest among patients with Vickers disease. Then we looked at also other cytokines, TWIG, APRIL, BAF, that were also elevated in the aqueous humor of patients with Vickers disease. And these 3 cytokines, they promote B-cell survival, differentiation, proliferation, maturation, immunoglobulin class switching, and antibody production. They are also in favor of stimulating B cells. Then I discussed also before that we had also another evidence for the involvement of B cells in Vickers disease, because we have histopathology from patients with sympathetic ophthalmia. And the histopathology of sympathetic ophthalmia is very close to that of Vickers disease. These were a group of eyes that I studied. Patients were eyes were inoculated because of sympathetic ophthalmia at the University of Ghent. And these were inoculated even many years ago, even at the time of Professor Francois in Ghent. So, and my colleague, Professor Philip Castellane, allowed me to look at the immunopathology of these eyes. And then you can see how the choroid is thickened with granulomatous inflammation. And then you can compare, this is staining for T cells and this is staining for B cells. So you can see that the number of B lymphocytes is more than T cells. Again, this is another proof that B lymphocytes are involved in the immunopathogenesis of VKH, and that depleting B cells with B cell depleting therapy such as rituximab, which is targeting CD20, it's a marker on B cells, will be effective. And then we published the first trial of using rituximab to treat patients with chronic recurrent VKH who are not responding to conventional treatment. So this is a patient, severe granulomatous anterior segment inflammation, and after rituximab treatment. Rituximab allowed us to control the inflammation with less doses. And this patient, in fact, this patient, she became depressed because of the long courses of immunosuppressive therapy, long courses. But once we shifted her to rituximab, the eye became quiet and allowed us to do for her cataract surgery. But of course, you see the pseudo segment damage. So rituximab was very effective in these patients and helped us to control the inflammation. So thank you very much for your attention.